Okay.
Good morning. Good morning, Dr. Samin.
Yes, good morning to the MPCSI conference good morning from Saturday morning of Mount Sinai with my all staff. You know, we are very good on Sunday. Saturday we are not as good, but we are always try to most of our meetings internationally by the time, because the time issue happens to be on Saturday morning. So that has become a routine, at least 1 to 2 live relays every month. So just let me start with on my right side, Dr. Kini, and we have two fellows here, which are Swati Rao and Maria Elena, and then we have our CVT, Asif and Naira, and nurses Will and Ashley. Imaging is Kiski, and we were part of a little bit of learning about the calcific lesions, and hopefully we'll take you to the next level with this presentation. So we have a case of left main, and that is what you wanted us to show, and the let me take you through the case. These are us, then Kiski has on. This is a patient, 60-year-old, has a known chronic coronary disease and multiple PCIs, and was admitted a few weeks ago with progressive dyspnea and Canadian Cardiovascular Society class 3 angina. Troponin were normal, and CTA showed very high calcium score and EF about 42%. And you see multiple CAD risk factors on the left side. Others are good except the uncontrolled diabetes, because A1C is 9.6, a high BMI of 37.9. Patient also has a multiple PTA procedures, as you can see, and also has some toe amputations. Rest of the chemistry is okay. Has a chronic dyspnea, and of course has, as I mentioned, few PCIs which will show, and now came with this more of a both angina and heart failure on good medical therapy. Look at the medical therapy, which almost everything which is available on the surface has been given to this patient, and patient then was found to have currently the distal left main bifurcation along with the right coronary artery. So we took care of the right coronary just few weeks ago. Syntax score was 31. This patient has been reluctant for surgery long time. Also because of the PAD amputation, surgeons are not happy also to take him for surgery. And here for the PCI of
Rota.
the distal left main. Okay. Now with that note, Anush want to show what we have. Let's go to the angiogram, please. But you can hear us well?
Yes, Dr. Samin, this is
Good.
Atul Mathur.
Atul, yes.
Yeah.
Welcome,
So
Atul.
seeing you very clearly. Yeah.
Yeah.
So we can see here EDP was high at 24, just mild LV dysfunction. This was the right coronary artery that was intervened last time. Even the right needed rotational atherectomy followed by one long stent. And this is where we are with the left. You can see the tram track calcium in the left main, proximal circ LAD. Now LAD, there is a stent, you can see that, but significant disease before the stent. The diagonal is a stent jailed, moderate size diffuse disease, and this is where we are with the caudal view.
So very calcified. I mean, we all know the imaging is the part and parcel of our PCI now. This left main, every guideline, ACS, chronic coronary syndrome, European, American, all will be class 1 indication. Question will be, do you want to image now? And knowing there's so much calcium, and do a plaque modification with the atherectomy, whether want to use rotational orbital, that could be a part of the discussion, and then do the imaging to really assess things and so. So with that note, you tell us and we can show what has been done so far.
The imaging catheter passes, then definitely we would like to have imaging first, because that will give us an idea about which type of atherectomy device and what strategy we would be using. So but first the imaging catheter has to negotiate through that lesion.
Beautiful. Very good point. Very good point. And I also say there are some lesions which will be very tortuous and long calcific. Don't try imaging, because many times the imaging can create a more trouble. So Anu, tell us what you did.
Yeah. So I just want to show what we did. Okay,
Yeah.
let's see.
So you are right. So they were able to advance the imaging catheter.
So this, though, you see there, if somebody thinks, okay, let me primary wire using either Rota or even your OA wires, not that easy. So this is a fielder and a fine cross. Okay. So just trying to navigate that LED, getting into the LED. This is the fielder wire.
Okay.
Then finally we get in. Same, it is getting into the diag, that's okay. Advance the micro catheter, then get into the LED. So after that we did the IVUS. We can show the IVUS run.
Yep.
We did the IVUS on the rota wire.
Okay, show the IVUS now, please.
This is
Okay,
the
I start to
Avigo
work.
Boston Scientific,
Yep.
right?
It's
60
coming. Yeah.
megahertz.
This is from the distal LED. We see the myocardial breach. Now this is the previous stent, like 27523 stent. There's a calcium behind stent, but no neointima. Now come to the proximal native LED, eccentric. We insert a 360 calcium and left main into the guide. So again, this is the mid LED, some kind of 275 stent at the proximal edges at the diag. And proximal to that is a native lesion, but we see the 360 calcium. And more proximally, it comes back to the like eccentric calcium. Then this is the level of the left main bifurcation. And at 6 o'clock, there is a calcium protruding inside. This is a calcified nodule. And come back to the left main. Left main also has some eccentric, like 180-degree calcium. Then come to the like OK landing zone, proximal left main. So it's a severe calcium. And the proximal already has previous stent.
So looks like the more calcium is in the proximal part of the LED rather than even in the left main.
Yeah.
But what is the lumen of the left main MSA? I mean,
6
minimum
point, I mean,
MLA?
distal is almost 6.1, 5.7.
Yeah, like around 6, but a lot of plaque burden, like a 60 to 70% plaque burden in the distal left main. Area is like, yeah, kind of borderline. And but left main at the bifurcation, like a lot of plaque.
5.4.
Yeah.
5.
And sometimes, sometimes Avigo doesn't show like a collect because of the artifact.
Okay.
Yeah, at the bifurcation, like kind of around 4 area.
So
And the
clearly the key is that once you have to take care of the ostial or proximal LED, you have to take care of the left main. That is
Yeah.
what we have learned over you cannot have exactly stent placed. So you have to take care of the plaque modification or stent strategy has to incorporate distal left main in this particular case, and more so, a little more of the left main so that we can do a pot. Anytime when we are working on the left main, I would say the pot is very important because of the vessel disparity. And think about people say, well, 3.0 stent can go to 5.0. Believe me, I personally have seen many of the plaque prolapse in those situations. So I would definitely go 1 millimeter more, but not more than 1 millimeter, although claim by every stent company has been nowadays that we can go to the next size. 1 second, with more than 1 millimeter square, so the 3 or 3.5 can go to 5, but we don't do routinely. So just coming back to the point, go to the angiogram again. Our slide presentation, severely calcified distal left main. Was there a disease in the ostial circumflex? Could you see it? Because we saw on the angiogram there seems to be some disease, but here nothing looks like ostial circ.
I mean, you really have to image the ostial circ
Yeah.
to understand. Just at the ostium, you don't see much. Show
Okay.
me the ostial LED.
Sure.
The question is, if we're doing rotational atherectomy, what size should be the
So this is the level of the left main bifurcation. I go a little bit
get
inside.
into
So
the
this is
ostial LED.
exactly the ostial LED, like 180-degree calcium. This is the ostial LED.
Okay. All right. So let me
So
complete.
we still have a 3-quadrant of calcium almost everywhere.
Mhm.
But the lumen, you see at even the tightest area, the lumen is just probably 1.9 to 2.0.
Yeah, exactly. MLD is like around 2.0. Not that-
Diameter. I mean, I'm talking the
MLD,
diameter.
minimum lumen diameter.
Yeah.
Okay.
So,
let
Dr.
me-
Sharma, would you
yeah.
like to discuss the choice of your
Yeah.
calcium modification
That's
device?
sure. That will be very good. Let's complete this presentation. Go back to the slide so we complete it here. Plan for imaging guided high risk stage PCI of the left main bifurcation using RotaTripsy and MiniCrush. Question is LV support. Always question comes in with a mild LV dysfunction of 40-42. Good EDP. No, stay here. That's 40-42 ejection fraction. So we thought that in this particular case we will do without using the balloon pump, or of course Impala, in my opinion, it will be big kill, but many of the circulatory devices now have incorporated up to 40% ejection fraction. So this is definitely low, and we know that you make it a recommendation based on the heart team, the STS risk score, syntax score, and various other frailty. The syntax score is 31, and STS score of 2.4. So with a guidelines point of view, it will be otherwise M patient, but why it is a non-invasive testings, because of very high calcium score puts patient in the high risk category, and the patient is of course diabetic, but after appropriate discussion will become A. So question then comes down to what are you going to do? As you know, protected PCI, this concept of the impala in these high risk cases, EF of less than 30, protect 4, 50 patients are left. And myself and German center, we are neck to neck with the 77 patients. We did one case yesterday. So hopefully this trial will complete within 3 months with additional 60 cases, and we'll have a long-term follow-up of me average 3 years and last case 1 year. And we will be a real major trial to answer the question of MCS in complex cases and so. So coming back to this left main, clearly we want to send for surgery, but this case after discussion getting the PCI. Only issue remain that what based on, we'll talk more actually, let's start doing the case, that calcium point of view, what to use, particularly when there is a superficial calcium versus deep calcium. And I think it basically turns out to be, once you have superficial calcium based on the calcific arc of the IVUS or OCT, you decide Rota or OA. We do preferentially rotational atherectomy. Somebody wants to use orbital is fine. Only two cases about, I would say, ostial lesion, Rota preferred, in a tortuous lesion, Rota preferred, otherwise orbital or Rota can be interchanged. One advantage of the orbital is long segments from small to large vessel with a different bury speed can be taken care. Anu, tell us what's your plan now.
So we have picked rotational atherectomy. I know even in the previous lecture which we were listening, there was a discussion which case why. I think again the discussion was based on the imaging, okay, how we prefer and what. That's what if you go back shows exactly what the calcium is. I know it is more of a superficial calcium. We need probably OCT to really understand. But just looking at this 360-degree arc of calcium, okay, every quadrant has calcium. So any device can be picked here. So orbital or rotational atherectomy.
Or for that matter, IVL, because IVL will cross in this case.
Yeah.
Yeah. Could be any one of them. And
that can be
Dr. Sharma, there
decided
was a discussion going on, like in OCT here, there was a nodule present. So Rota doesn't work in nodule. There was a discussion going on.
No, but who said Rota does not work on nodule? We have at least 7 papers on that.
Yeah. Now, this question was raised during the live case last time also. Somehow they have this thought process. Rota does not work in the nodule. We have published several
people have published
case reports. Yeah. Actually, Rota probably is what we are saying is, do you have the nodule algorithm?
Yeah,
we can show you the nodule algorithm that we published in ESC, and it has come out as a paper. It is nodule will respond either to Rota or OA. When you decide to do OA or Rota, it depends on the calcium arc around the nodule. So if you have a large calcium arc, then okay, OA may be working. But if you have a nodule and then the arc is about only 180, that is when rotational atherectomy works. Both Rota and OA works for a nodule.
Yeah, I know. Where is this word coming out that rotational atherectomy does not work for nodule? My friend, earliest papers were all with the rotational atherectomy with a nodule. Yes, orbital may do a little better job of shaving the plaque, but orbital will be good if there is a calcium around also. But if there is a normal segment of the vessel, orbital will create a massive dissection. And that is what the problems happens. You know, you saw the dissection, more perforations and slow flow occurred in the Eclipse trial, because OA with nodule, but also there is a sheet of calcium around, OA will be better. But if there is not that much calcium, because OA will be, remember, kind of ablating into those normal segment and doesn't deflect classical of the OA, of the rotational atherectomy. But traditionally, nodule has been responded very well to Rota, maybe little better can do with the OA, and including shockwave. Shockwave will work with the nodule also. And we actually also have a paper in the JACC case reports, shaking or shaving. The shaving is by the rotational and shaking is by IVL. So all those techniques will work in the nodule. What will not work, I would say probably, is the cutting balloon alone. It may give rise to some fracture, but it will do more of to the normal segment.
So does
Okay.
the wire bias have an important role whether rota will be affected or
Yes.
not?
So yeah, very good point. So I think the wire bias, you just be careful with the wire bias. Many times wire bias is our friend, will give you bigger lumen than what you expect with the burr size. Here we have selected 1.75 burr. Yeah.
So if you think there will be wire bias, I think that was the case we did for India Live. That's the time you go with the smaller burr size.
Yeah.
Yeah,
That's
because wire bias can give rise to dissection and perforation. Perforation is one that interventional cardiologists should understand. This is the case that could give rise to perforation with the atherectomy device, and try to go to a smaller size device or burr.
All right, so we'll have a lot of discussion and we continue now. But I'm a little surprised actually. I didn't hear in any of the other meeting. I know you said you did. Why wasn't there last time? That the word has gone because our Indian interventional community is very intelligent. That this word floating, that rotational atherectomy does not work on the calcific nodule, is a total misnomer, and I would say not. It's not based on any fact. Yeah, good. We are ready with the burr now, 1.75 burr for the distal left main to the LAD, and then we'll see or the ostial circle later if something need to be done. Very calcific, 3 steps.
Yeah.
As you can
It's
see.
here we are moving the knob here, and then with the Y connector backward forward. Then you have on the dyna just tap and check.
No jumping, go.
Yeah.
Keep going. Yep.
So we'll start a slow packing motion.
Yeah, this is the tightest lesion before the stent in the LAD, which is a full circle. It's a 7 French guide and 1.75 burr with a rota floppy wire. Want to do one more?
Yeah, I'm going to do one
And
more
you see the
policy.
hemodynamics always follow. Systolic pressure should not go to less than 100. And of course it is. Then give the neosynephrine injections. Our nurses are fully trained. They won't even ask us. Anytime blood pressure to 90. No atherectomy, whether it's orbital or rotational, because that will start the circuit of having a slow flow. Good. Just complete now the polishing. Now a lot of people do slow polishing, slow burring, maybe getting a more orbital type of effect with the rotational atherectomy. We are not a big believer on that.
Okay,
Good.
come out.
Okay.
Give me fielder and run through.
Yeah. Okay, we are ready to come out now. Yeah. Any question, Atul and other team?
Dr. Sharma, this is
Yeah.
Dr. Anand Rao.
Yes, Anand, yes.
We discussed this last time. What is the burr speed you keep at this moment? I mean,
What?
is it,
Oh, yeah. So very good point. So what I did is,
140
yeah,
40 versus 180.
very good point. So what happened is this Rota Pro, which you have, I worked with the factory of the Boston Scientific. I went their plant. I mean, I don't go to any company plants, but since Rota is by my heart, I went there 2 times. So right now, your Rota Pro comes set at 150. So you don't have to touch any buttons. You get it on, it will be 150. So what we have felt that 140 to 150 ablation is okay. It's probably cause less slow flow, may cause less chest pain and perforation. That has been our data. Now, answering the question, can I be on a scientific basis? We did publish back in 2004 when we did this slow speeds of 140, 150 compared to 160 or 180. There has been a trial from Japan of 100 patients, 50 in 140,000 speed, other one is 180,000, and there was no difference in CK release and slow flow. It was a short trial, acute procedural trial, having the 140 or 180. So coming back to the point, what we do, we go with the slow speed, 140, 150, and so, yes, if 5 times you could not go through the lesion, then you crank up to 180. So that has been our policy at present. But key is that usually why slower speed? I can tell you personally, I have seen that it does patient tolerates a little better, and there's less chance of dissection. Same thing actually I'm saying, and perforation. Same thing I'm telling orbital team. That orbital perforation, when we started using, I did the first case here in India as well as first case in, America as well as in India of the orbital. That orbital trouble is the high speed. You know, we have the mini crown, which was 40 and 80,000 RPM, which is taken off because there was the design issue. There was a tip, and then there was a gap, and then at the convex border. So that mini crown of the orbital will not be available. Will not come to the market. We did the COAST trial, COAST, America and Japan together of 100 patients. But key is that they have a speed of 40 and 80. And I'm actually telling the orbital team, you should have a speed of maybe 60 and 80. Take away 120. You do not need very aggressive, very good device. 120 is the one where the trouble occurs. And I know about 12% of cases in the Eclipse trial, they use 120. Now, maybe those were the very large vessels, 4+, but they had a 120 alone. Many of them were both means you used to use the 80 and then 120, but about low teens were used high speed. And you all know the perforation rates and so of higher in the orbital compared to balloon angioplasty group. So just coming back to the point is that we go with the 140, 150,000 RPM, and that's good. Does its job, and if does not cross after 4 or 5 times, then you can crank up the speed.
Okay, go IVUS to the LED now.
Now we are doing the
IVUS
IVUS to the LED.
Okay. Start back again.
The last angiographic shot shows a very decent picture of the circ. Do you think
Yeah.
you'll
It's
image
coming.
it, or
Yeah, we are going to image the circ once
Yep.
we do the LED.
Yep. So this is the previous stand. I'll come back to the native. This is a flux LED. Post loaded,
Okay, good.
and then we'll stop it.
So show us the ostial LED.
Sure. So this
Okay,
is flux
yeah,
LED.
you can
So yeah, this is the bifurcation of the left main. Just inside this. This is the ostial LED. Then more inside
You
is
can see very good debulking at the ostia.
Yeah, definitely
some
lumen is
some
fractures
flux
and a little
modification.
interruption. Yes.
yes.
You want to, and then we have put a rota wire is out, right? And then put a run
rotavar
through
is
wire.
out. We are going the IVUS of the circumflex.
Yeah, and
Yeah.
so
Flash
put a
Possible some
fielder wire
flashes
in the
flux
circumflex.
LED.
And the whole question comes down here that if you have a good lumen of 5 millimeter, 4.5 or 5 of the circumflex, do you want to just put up one stent strategy? Now he's a young patient. I'll try to optimize as much as possible. If there is a lumen compromise of the ostial circ, I think we put a MiniCrush. That was originally plan was, but we'll take your opinion, our panelists, and see what happens. Many times when we think there is no plaque, but once you do a work on main vessel, plaque do shift. So this one was our original. Okay, what is the
PC,
prediction?
show us
Lumen
the
will be less than 4 or
nodule.
more than 4 of the circ. Let's get
Yep,
the
so-
panel's opinion on that.
No, more important.
Anyway, we start to work.
Yeah,
This is
Okay.
from the circ.
this is the circumflex.
Oh,
There's a nodule there.
There is a nodule in the proximal circ.
Yeah, there's
Yeah,
a
stop it.
nodule in the prox circ. I need
Yep.
to see the nodule of that distal left main LED.
So this is a pullback from the circ. So this is left main, and this is I see the LED wire from the 2 o'clock. So now this is the left main bifurcation. Go inside. So this is a ostial circ, and a little bit more inside. Yeah, there is a
Flush again, yeah.
calcified nodule protruding inside. This is a proximal circ. Yeah, circ also has some calcium, like 180 degree of the calcium, and like a huge protruding calcified nodule in the proximal circ. And
But
the
give us a CSA around there.
yeah, and the
Just a
area wise
CSA,
1 second. So this is like kind of estimated because of the not completely coaxial.
Go
The-
back to the LED left main, distal left main LED where
Sure,
the
sure.
nodule was. Let's see.
This is the LED wire, so this is exactly left main bifurcation.
Mm.
Let it go inside.
Mm.
So yeah, around here is the ostial circ, and the estimated area is like 3.8. This is the ostial circ.
No, understood. Go back to the previous run.
Oh, sure. This is the second one. This is the LED after the loader. and come back to the proximal native LED.
Remember we had seen the nodule?
Oh, sure. So actually the left main bifurcation has a nodule, but this is kind of deeper part. So
Yeah, okay.
yeah, and like wire is here, the rotor might not touch this part. Maybe rotor shape the opposite part. Yeah.
What I would suggest we have to do, we do 3.5 IVL,
Yeah.
okay, because you see that
Yeah.
diameter is still about, okay, 3.5 IVL from distal left main to LAD, okay,
Yeah.
and I still think circumflex will be compromised as soon as we stent, single stent.
Should not be done?
No, we
Should-
should
will
do
be.
two stent strategy.
No, but because you saw the big calcium nodule not at the ostium, little further down.
Yeah.
In
It will
there,
be
so
compromised
and you
once
have
we
the
do
IVL there, and I always say the diagonal
Open.
OMs, you do only atherectomy, rotor, orbital if necessary, and you cannot get the IVL in. So I think this will be a case, and let's take the opinion from our experts there, that would you touch anything to the circ? If you want to see that IVUS, we can show that IVUS once again. On angiogram, let me show the angiogram first and then the IVUS. So this is there, and this is our picture. It definitely looked a little hazy and
Yeah.
some lesion. See that it looks like some calcium which we saw on the IVUS.
Yes.
See that anytime you see that haziness usually represents the calcium on one wall. So my inclination, and let's get from all our experts, I know from here, based on this, I know Atul is there. Is Praveen Chandra made there or no?
No.
No, Dr. D.S. Chadda, Dr.
He's
Jaspal
also
Arneja.
So if we analyze the IVUS from the circ left main, the
Yeah.
circ ostia is all right, not that compromised, but there
That is correct.
just after the ostia there is a nodule.
Yes.
But
Yeah.
when we put a left main LED crossover stent, the circ is going to be pinched. So what my opinion is that we should do an IVL from left main to circumflex covering that nodule
Good. Perfect.
before putting a stent.
Agreed. So that is what we are going to do. Yes.
Or the angle between the LED and circumflex is quite reasonable. So, I mean, if you do a provisional strategy and then the bailout as a tap, how is
No,
how is
no,
that?
no. No, I can tell you, we basically we say that
I think a
bailout
bailout
only, we are not a
strategy,
believer. If
especially
you
with
think
that much of
they need to be
calcium
taken
around
care,
there,
just go
that's not
forward
the
as a primary
good idea.
approach.
I think based
We
on
in our lab, whether
definition
Rota
trial,
or any other
VK5,
two-stent
everything
strategy,
we
we
have
are
known
not the
that if you
bailout.
have true-
So bailout,
Here-
Rota occurs in less
true
than 1%.
bifurcation.
Bailout,
Okay, which
two-stent
is here.
approach occurs
Okay,
in
but I would
3% or
say
4%
it
of
is
cases.
not 1,
Because if we decide with the
probably
two-stent,
are
go with the
1,
two-stent.
1.5. That if you think that you
Give me the key.
have to do something, then go with upfront two-stent strategy. Okay, go. So
Yeah,
we
bailout with
actually
a
are
calcium
doing
nodule over there may be messy.
yeah, we will not be able to cross, and we go through this every day. So right now we are doing from left main to LAD. Okay, go 8. Yeah, 3, 5 to 8. The question you could ask me is why did we have to do IVL? So if you see that, I think truly speaking, based on the diameter of the distal left main to LAD, 1.75 burr was small. It was almost, like I said, 1.9.
This slide.
That is why the Rota probably did not do a lot of ablation there. So
This
we
slide.
have
The
to
LED
do something.
ostium looked very well treated with the rota. There were a lot of reverberations and evidence of
Good,
fracture.
good.
Good.
Why
Yeah.
don't we just use NC balloon for preparing the ostial
Copy
LED
Well-
instead of an expensive IVL?
No, but I think
Yeah.
still there is a full circle. Remember,
Yeah.
it's a full 360-degree circle. There are some calcium fracture did occur, but I think you need to optimize it a little better, because in the end, we'll always otherwise see a little dent on the top. We'll see a little dent on the top. But yes, if you want to, I would say other one, you want to just do with a cutting balloon. You want to go to open NC, maybe, but you need to do a little more than just regular NC here, because there is such a calcium, and we know for cracking the calcium or calcium fracture, best job is the IVL. Then, not it. Then comes your Rota and orbital. Now, what has been shown when the very calcific lesions, like we have done few trials now, there's the latest one being Epic 22, which compared IVL, Rota, and laser. What has happened? Everybody has seen now the laser gives inferior result in the heavily calcific lesion. So that's where I would be, and of course it does not have any effect on the calcific nodule. So laser, yes, but less than optimal in terms of outcome of the calcific lesions. It's a great device in ISR, unexpanded stent and uncrossable lesion, but in the calcific lesion it does not give you what we expect. So therefore here logic behind combining IVL will be that just to get a little better lumen expansion before stenting. Now, if I'm doing this case in Jaipur ESCC, I'll just go with the cutting balloon. I would not go with the only high pressure, just will go with a cutting balloon because I want to get a little more fracture in that calcific arc in for further expansion. Now, purpose here is it will serve two purpose IVL. That will do the ostial circ also or proximal circ with that IVL. So we'll do because 120 pulses, and now actually we are working with the new devices. There are 3 devices are getting into trial in United States, and I see many of them being seen in India also. These IVL type of devices will be available, and they're getting into trial, and one of them has 200 pulses. So clearly the 120 pulses will be able to use both of them. That's fine. Do it here and then we'll go. So this is a 120. So we how many pulses used so far?
We used a 4.
4.
40, yeah.
So we still have 8 more, and see that this is always a limitation of our first generation IVL or shockwave, which is, of course, things are getting bad. They are working on it to make it a little more flexible.
Do you also encounter ruptured IVL balloons?
Oh,
Because
yeah.
In India, we
Yeah.
used to.
We have seen some. We definitely have seen some ruptured IVL, and what it does not cause perforation, but the dye goes inside the vessel wall adventitia, like type 1 Ellis classification, not classically 1 and 2 maybe, but not the 3, not the frank perforation. We have never seen IVL ruptured balloon causing the frank perforation, but has created a Ellis type 2 perforation.
We have shown it in 2 live cases. Okay, both were to India. That what we have noticed is like this circumflex, right? It is not 360-degree calcium, not even 2 quadrant of calcium. The likelihood of developing what is called as hematoma, some kind of dissection is very coming out.
Yep.
Is common. So let us see. So let me show you what the angiogram was after we did look at this. Already compromised circumflex. Yeah. Just with the balloon of the LED.
An Indian IVL also available.
Yep. Yes. I see the Indian IVUS. I got the Indian IVUS also, Indian IVL, the Indian mitral clip. So a lot of good things are coming.
Indian OCT is being.
Okay. And I think the next one what India really needs is the Indian Impala. That's what we need. Big. Yeah.
That is also coming. Yeah.
That's it. So once we have it, this will be because otherwise it's a so expensive devices, useful in certain cases, but the expense is so tremendous of 16-18 lakh rupees just for the adjunct device similar to.
We'll export it to US while Trump does not put tariffs.
So going back to here, remember just with the balloon of the left main to LED, circumflex was compromised. So this is a telltale sign that in this kind of a situation, even now we have ballooned, okay, the circumflex. So initially, remember there was, look at this, which we had a little bit of a
balloon into
Right.
Yeah, so you can see that is a little bit of a dissection. Probably if you image, we probably will see some hematoma also in the circumflex now.
We get a 3.5 and 3.52, 3.512.
No, earlier remember the discussion was we could do Rota, we could do OA or plus minus IVL. The current generation IVL, I can tell you, we probably would have had some difficulty even getting into the LED.
Of course. Okay. So now, question is, let's talk about the distal left main. Our plan is to use the Zions, I know, expedition there. Here we have Sky Point, sizes wise.
We have 3.5.
Yeah, 3.5, 30, 28 and 3.5, 12.
12?
3, yeah,
okay.
Right. Give us that.
3.5, 12. There is a time. Did you want to quickly? Oh, no time.
No, we'll
Just
show the nodule.
7:15.
We'll end up with our nodule paper
Yeah.
algorithm to giving 30 seconds in the end after quickly putting these two stents with a MiniCrush. I think with this, so just coming back to the point, the stepwise approach of
Show
EBC
the
main,
MiniCrush,
Yeah.
Rich.
EBC main that do every case kissing balloon dilatation.
12.
Yeah, go quick.
No, this
No,
is
no,
12.
Huh?
Left. I want the circumflex.
Yeah, circumflex
500.
first.
This is what 28 they've
Yeah.
given us.
Yeah, 3.5, 12 or 15, whichever you have. 12 or 15. Yeah.
15.
Yeah.
Open.
Yeah. So key is that if we not a believer of that also, the EBC main strategy, that if you are doing a provisional and there is no lumen of the side branch compromise, just leave it alone. Don't go through, because from Epic data, the earlier our left main, the data Excel. But yes, some people will do a kissing balloon routinely because we learned from there. Single stent, routine kissing balloon was not good, rather a little harmful, and slightly higher trend for stent thrombosis. So right now we are clearly, because of the treatment of the side branch and the lesion in the side branch by imaging, we are going with two stent approach, MiniCrush, that was the original plan. And we have 3.5, 15 into the circumflex, and we have 3.5, 28. For the mid left main, we give enough time. Left main, you need a 4 or 4.5 dilatation.
We
best
have a
series
4.
4,
Huh?
8.
Yeah, best series 4.5, but diffuse plug maybe 4 low is safer.
4 is good.
We have a 408 ready.
Yeah.
Open the 408.
Yeah, and the pot balloon which is available in India is also come to America now. We have used a couple of them, but we are going to go through the process of keeping in our inventory. And I know with the time frame, we just finish it shortly. Yeah.
The shortest size is 6 millimeters.
Right. Yes. But it has come to America.
Dr. Samin, is your default strategy in this left main you are using MiniCrush? So usually
Yeah.
in every left main you use MiniCrush, or
Yeah.
in some cases
Yeah, with MiniCrush. MiniCrush in we do a DK crush, particularly if radial. I'm going up to the circ. Yeah, so the radial, because of being a 6 French, there we'll go with the DK crush, but otherwise MiniCrush is our preferred approach. We rarely do culotte or tap. Though even if, let's say, we had to use a bailout in the single stent strategy, we'll go with the reverse crush. So I think the tap to me looks good. Acutely is a simple to do.
Some die, just make sure.
It's a simple to do, but problem is once patient comes back, advancing is a little difficult. Once you develop restenosis. So tap, we are trying to keep
some
it
dice.
away. Good.
Okay, good. Go up.
Okay. Now this is the
Oh, wait.
So you
Wire.
leave your wire inside.
wire. No, we don't take it out. No.
Good.
Definitely
No,
wire.
wire comes out.
Wire has to come out here. This is part of our teaching up there
You
also.
can see the 3D app showing
Yeah.
all the steps. Keep going. 408.
And leave. I see a lot of investigators bring the balloon up and within 5 seconds goes down. Remember, you need your balloon pressure to go up to the tip of the balloon. I would leave at least about 8 to 10 seconds. Let the balloon be inflated and then you take out. Now, there are data that your longer balloon inflation may give you little better MSA, and so, although we are not a believer of that, some people are doing oscillation. Actually, oscillation used to go back in our balloon days when we used to crack the plaque and then tack it up by doing the oscillation to 20, 16, 8, 16, 8. I know many of those things are coming back now.
Yeah, we remember those.
Yeah, good. Let's take a picture. Sine. Beautiful. Good. Okay, so now before we end up, so since now it's become more routine.
Spot recross quiz, you can show the algorithm.
So can we go to the next slide? So just wanted to take your time, and you'll tell us if any more time available. We can show this. Show that calcific nodule slide.
Dilip? How much left? So we have around 8 to 10 minutes.
Oh, well, then sure.
They started late.
Yeah, that's good.
Yeah,
Okay.
you can take your time. Yes.
Okay, good. So let's show. Good, good. So first we are doing the pot and then recross and, no, but you do a pot first or you are
No,
going
no,
to
we are doing pot first and
Okay.
then we'll recross. Yeah.
Okay.
So here,
So pot is with the 4.0
4.0, yeah.
or 4.5?
Now, yeah, he said 4.5, but will go 4.0, yeah. Calcified, and it is not that it's a normal vessel.
Do we have
Plaque
4.25
everywhere.
balloon or no? Right? There's no 4.25. We are only 4.5.
20.
Go to 24.
No,
Yeah.
please.
So in MiniCrush, sometimes the wire has difficulty to pass in the side branch. What are your
Yeah.
tips and
Got it.
tricks?
Yeah. So that's a very good point. So, so that is one of the, if I would say any negative of the DK crush or mini crush is the DK crush, because you open the ostium before you're putting the second stent, it's a little easier. Does happen with us. I mean, rare case, I would say. I'll remember that we regret it. That's one, yeah.
Just making
Not yet.
sure.
Not
Yes.
yet.
Okay.
Yeah.
Good.
So
Done.
that the mini crush, but here the point is same. Using the hydrophilic wire, make a curve, and then not paying that much attention whether you are going to the proximal strut or side distal strut, just optimal
Cell.
optimal
Proximal
cell.
cell or distal cell. We
Yeah.
never pay attention. We call optimal cell.
Optimal cell.
If
You
you
get
know
into
you are in
here.
the optimal cell, you know the balloon will go easy.
And we are going to do it now. Let's go to the circ. Same wire. No, don't go on the slide yet. Tell this guy. Good. Yeah. Okay, so this one, now we are going to the same wire which we have earlier.
That has been sitting in the guide. So
Yeah.
let's see the tip is okay.
Yeah.
And then
Have you ever tried those angled micro catheters?
Oh yes, many times. Sometimes it's if really difficult. Then all weather venture catheter and your supercross 90 120.
oh
So we need a new wire,
yeah,
new
this
fielder.
tip is gone.
Yeah. So yes, rarely needed, but sometimes particularly for the left main, no, left main you'll be able to go through it. Toughest thing happen when you go into the LED and diagonal. That's where to making that curve. That where
2, 3,
so
5.
difficult
3, 5, 12
sometimes.
to the
So
circle.
difficult sometimes going into
And
that
3, 5, 15
the
to the
diagonal.
LED.
Even the wire goes many times. Device do not go. So even go with the 1.0 balloon. I know we don't have a smaller 0.5 or 0.75 which you guys have. Here 1.0 does not go. Then we do use a Corsair. Sometime it open up the ostium and so. So once we are ready now. Yeah, sorry.
We have a Nick nano balloon here, which is 0.8.
0.8. Yeah, very good. I'll use it. Fantastic balloon. Unbelievable.
If you're not able to cross, now your question was how do we get into the side branch? So just see the wire movements, the finger movements, how you go into the left main. So people will tell, so you can see how my fingers are moving.
Good.
You're not using a talker.
Yeah, no
You
torque.
have seen all my live cases, no torquer.
Okay. What balloon we have? Compliant? What do we have? Okay. What balloon you need for that?
No, we said 3.5, 12.
Okay.
Ever since the pandemic, the newer balloons, we find it way harder. If they don't recross, then we may have. Now this is a compliant balloon, non-compliant balloon. It may not go into the circ. Okay. If it does not, then we have to take with the smaller compliant balloon and then go in. So we are right now going with the
3.512 for the circumflex. And then we'll go with the, if not, then we'll go with the 2 or 12 to make a room first.
Have you ever encountered?
Okay, now you see this has gone. Now the balloon has gone. This is what I say. Cross through the optimal cell. Okay, so we cross through the optimal cell. We did the proximal optimization of the left main, recrossed, and then we get into the kissing. So going back to the question, how do we get in with the wire? I mean, we always like, again, during the live case of some place, a lot of people were commenting that they like to use non-hydrophilic wire. We have repeatedly been teaching and we show, and in the apps we say hydrophilic wire are easier to cross into the side branches, whether it is after stenting, before stenting. So even here we have used fielder, that is our workhorse wire for everything. If somebody wants to use Whisper or other polymer jacketed hydrophilic wire, we are okay. Now this we know will be a trouble. What do you want to do?
No, open the
Circ
open the
first.
circ first. Yeah,
Open the
we are
circ
there.
first.
Good. Okay, going up now.
Down.
Good.
So once you've seen how the movements of the wires are, okay, 3 fingers, you keep using this technique to get in. If the balloon does not go, then you may want to recross
this
and
one.
get into the right cell again. Okay, good.
Yeah. So see, once we opened it, it went without any problem. Go up.
The
If
alignment
you,
changed.
Yeah,
yeah,
that's
and
right.
then down.
And everything looks up to the proximal area. Yeah, good.
Okay, down. IVUS. So you will go into the right cell. If you, despite that, you don't have a balloon that will cross. Now that's the time you will change. Instead of 2-0, go 1-5. We have our smallest is 1-1-0. You guys have smaller than that. Try that to get in. And even that does not go. That's the time we will say, try to use Corsair. But those are probably in a year between the two of us who do the highest bifurcation cases here, we probably will have used in 3 or 4 cases in 1 year, each year.
Yeah. So just to
It's
come
very
back to
rare.
my time, do we ever have a case where we could not do a kissing? Yeah, sometime. But only problem is we'll be able to do a serial, but not necessarily kissing. No matter what you do, your wire entangle. So serial dilatation. That's okay as long as you have dilated both cells sequentially. Means the sequential or serial dilatation will be okay. So going to the circ.
We're
Okay.
going to the circ.
All
We're
right.
going to the IVUS with the circ first.
Yep.
And I think if you do circ looks good, that's okay. All right, so we are not taking any pictures yet. We are just doing the IVUS of the circ, and I know we are reaching to our time. I'm very cognizant about it because we want to take you to the end of it, not stop in the middle. Good.
Okay,
check the
distal
image.
edge.
We have around
Yep.
Yeah.
Okay. Native.
2.5 minutes more.
Okay.
Start
Good.
clock.
Beautiful.
Come
It's
on.
coming.
Dr. Sharma, after the
Yeah.
kissing inflation, you
Yeah,
would not
nice.
like to do a pot
Nice position.
Yeah, that's a very good
Because
point. That will become the
There,
repot.
yeah.
Yeah.
Left
repot.
main.
Yeah,
Yeah.
the proximal distortion of the stent is
I'll
there.
stop it. So yeah, this
Okay,
edge looks
go
good.
back to the proximal. Yeah, good.
Yeah,
Left
like on the
main,
plug,
come to
but
the left main.
yep. The stent is expanded. Then this is the osteocirc, kind of eccentric shape because of the calcium behind stent, but area is 7. This is the osteocirc. This
Very
is
good.
bifurcation. This is left main. Left main area is
Good.
like 11.
Okay, beautiful.
Actually, slight malposition because of this block here, but
Yeah.
we cannot perfectly oppose here.
Yeah,
So
that's good.
just a slight malposition. At
So
the
go back to the left main.
Yeah, this is the left main.
Good. Just stay here. Because right now there was a discussion after kissing, there is distortion of the stent.
Oh,
So by imaging, we are proving to you that once you kiss, there is never a distortion of the stent. And we have published in JACC,
Repot.
repot, pot, and repot, that there is no data.
Yeah.
Absolutely no data.
Left. Yeah. Go to other. Yeah. So I think that a lot of people do few things, which is okay. But to me, I think once you've done the kissing and then you've done the pot, that's good enough.
No, first pot,
Yeah.
then kiss, and then we never promote repot.
In
And-
the
and-
longitudinal view, we are seeing a narrowing at the distal edge of the stent, circ stent.
this is a native plug
Here.
because
Yeah,
circ has a
yeah.
diffuse lesion.
So is that a geographical miss or something or what?
I mean, there's not good heresy landing zone.
It is diffusely diseased vessel. We
Yep.
are on the plaque, but go back, give us a CSA on the plaque.
Okay, this
Good.
stent
So-
area is perfect.
Yeah,
but,
stent area is perfect. It is in the plaque. That's number one. 2 things you see for. Ideally, you should place it where there is no lesion. But in this kind of a case where it's diffuse disease, even if you land it on the plaque, there's no dissection. That's the key.
Yeah.
One, it's fully opposed. Okay. And it is opposed. After opposed, there's no dissection, even though it is on the plaque.
Wire is bent here.
Yeah. The wire is bent.
Okay. Yeah. So
Right.
then we are going to do the LED now.
Yep.
And
You can, you showed the,
just finish this, and we got 2 minutes. So that we got 1 minute to show the limb left main to LED and 1 minute for our slide, and we are done. And has been a very provocative, very interesting, I would say, enjoyable discussion of the case, and that is what we need to do, learn from each other. Sometimes some people just take one opinion and just keep hammering on that in those live cases, and we are telling them that this is not a right approach. But it's a discussion and learning from both
Can you
sides.
show the IVS?
No,
Okay.
so
Okay,
this was
start
such a
to work.
complex case which you have made
This is
made
from
it
LED.
so easy and discussed it so well.
Yeah,
We
no
really
gap.
appreciate
Flux
the
LED.
procedure that you have done today.
Left main.
1 second. What happened to this guy?
Nice.
Yeah, good. Do it again. Show it.
Yeah, I'll show you again. So
Okay.
this is the previous stand. Now come to the proximal stand. This is today's stand. Yeah, we're expanded like area 8, 9. Now come to the left main bifurcation. So this is the osteo LED, like areas like 9,
Beautiful.
10. We're expanded. Then left main. Again, we're expanded. Just a slight
And
malposition.
what we saw clearly, the left main, no your distortion of the deformity with the kissing which we did, and we can get to the last angiogram slide first. Sorry, last cine, and then we'll go to the last slide. Okay.
Your left main MSAs
Yeah.
were liberal 27, 28.
Yep.
Very, very nice.
Sorry.
The combination of strategy. Okay. Can we just
12, sorry, 27 is the EL, better
Yeah.
side.
Ready?
Dr.
Go, go,
Sharma,
go.
Dr. Ankit here.
Yes, Ankit.
One quick. So when I was in Mount Sinai, when you are doing a final case,
Yeah.
do you still prefer both NCs or one semi-compliant
Both.
and
No,
one NC?
no, I think we learn more and more NC. You need to do a NC. Now, don't go 18, 20 atmosphere with both them. Go to 12 to 14 only. So that's where many times the proximal distortion occur. You go both of them 24 proximally now. So that's the only region. But yes, we'll go with a 14 atmosphere, both of them, both non-compliant. If we can get to the last slide now you can show the nodule slide. Here, AK. Yeah. Just give us 1 second and we'll go through it now. Yes.
Okay, this is what we presented. Actually, Kiski did the late breaker of ESC, presenting how do you manage this calcified nodule. So if you see there, many of the time there's the imaging never crosses. So then you have to decide upfront OA or RA, whatever you are comfortable with, and after that you can do intravascular imaging. So whether you are doing IVUS or OCT, that is how you will see the nodule. And we always know there are two kinds, eruptive and non-eruptive. I'm not going to get into the discussion of that, but this is what we Mount Sinai studied, and this is what we have published. So this is exactly what I was asking, what is the MLD at the level of the nodule? So our MLD was almost 1.9, 2.0 at the distal left main to ostial LAD. So based on the MLD, then we decide, you see that, if it is RAOA. If the MLD is larger, right, suppose your MLD was about 2 or 2.5, but then there is still arc of calcium is more than 270. Here we had arc of calcium more than 270 and a calcific nodule, right? But our MLD was borderline. But we decided RA, then look at that. We say consider IVL. This is where the discussion comes, that when should we consider IVL? Definitely when your arc is more than 270, which we saw in this case. And that is why you get a final result. You show the MSA of the ostial LAD distal left main is because proper calcific modification. But if your MLD, see if your calcium arc is the calcific nodule is there, and if your arc is not 270, even though you see that you can do RAOA, but then you can consider just a high pressure balloon at that time. But if anything, everything no, then you can do high pressure balloon or cutting balloon.
Yep.
But important what point I guess we can go from this live case is that nodule can be treated with the rotational atherectomy, and plus minus IVL, okay, is depending on the calcium arc around that nodule.
Okay.
So Dr. Sharma, Dr. Kinney, on a Saturday morning, you have done such a lovely case to show to this audience. This is a fully jam-packed hall over here. Dr. Ankit, Dr. Dilip, and Dr. So it's a big team over here of MPCSI. This is the first meeting they've held.
Yep.
And they're really proud that you have performed the case over here. Big hand for you, sir.
Thank you. Thank you for inviting us. Beautiful.